pretty similar theme here. Also, case of colitis.
Sorry, I have a question regarding ischemic colitis. You know, when I see cases, typically, or read a report, there's a differential diagnosis: colitis, infectious, inflammatory, ischemia. Is there a way to say if you think it's more of infection, inflammatory versus ischemia, instead of just giving a long list of DDX?
Artie?
We mentioned distribution, so if you have like watershed zones, you think more like ischemia, but are there other CT findings that would, help us lean towards ischemia versus infection?
So I think the demographics are essential, and the presentation, and basically prior history. But I also find that marked wall thickening appearance in a segmental distribution, such as in that last case, is pretty classic for ischemic colitis. And so in a patient who has risk factors for that, we could suggest that higher up, and pretty much didn't really say that it was this infectious or inflammatory, but that's because I just had a strong suspicion that that was going to be ischemic colitis. So I know in terms of trying to order the differential, it really, I think, just depends on the presentation and symptoms.
Gotcha.
But that appearance and distribution also is pretty typical. Okay. Now, this is the second case of colitis. I'll tell you that this was also called infectious or inflammatory by our more senior resident.
We have residents if you wanted any volunteers.
Well, what's the most significant finding here? Anybody?
The colon looks kind of mildly thickened and hyperenhancing.
Yeah.
And there's a little bit of like pericolonic stranding and a little bit of free fluid. It doesn't look particularly thickened. And actually, what's going on there? Is there like pneumatosis or in the sigmoid colonic wall?
There's definitely something funny going on here.
Or like an extraluminal collection?
That is indeed what this is. So this was unfortunately missed because whomever was reading this case was so convinced that this is just a simple case of colitis, but this is pretty severe inflammatory changes. And also, this is not only an extraluminal collection. When they're reading this case, they should not have missed these foci there, which are harder for us to see quickly during a case conference. But this person clearly had a perforation. Any thoughts? Is the etiology of this our theme today, at least of the two cases that I'm showing? Colitis. So what variety of colitis would this be called? Anyone? No, any of your residents?
No, we don't have any volunteers, but I was just, as I was looking, there's quite a bit of stool.
Yeah.
So it's diffused throughout, and they look desiccated.
Yes.
So I was thinking circle perforation.
Yes, that is correct. that is precisely what this is. So this was thought re-op diagnosis was pneumoperitoneum and peritonitis, but on surgery they found stool ball in the peritoneum and pus, and so this is basically a stercoral perforation. So stercal colitis, something to think about when you see a large amount of stool, and it's usually in a very elderly person, and that pressure on the colonic wall can actually lead to decreased blood supply, and after a while that pressure can also lead to perforation. So it's thought to be associated with high mortality rate when there's chronic perforation, especially if this patient was discharged with a diagnosis of infectious colitis, just given some antibiotics. So this is an article from AJR that shows this 80-year-old woman with large amounts of stool in the colon, and this collection here, this is a perisigmoid abscess. And this second image here shows 3 days later, continued fecal impaction and increase in size of this abscess, and that surgery confirmed multiple stercoral ulcerations and essentially perforation. All right, that's all I have.
I have a quick question.
Yeah.
So how often do you see it in the colon versus in the rectum? I've seen it, I guess I've heard of it and thought of it more commonly in the rectum, where there's like a big fecal ball and eventually there's wall thickening and sterculitis in the rectum.
So in the handful of cases of perforation that I have collected, most of them actually have perforated around the sigmoid. But the rectum is usually where that massive distension occurs, and that's where you get the sterculitis. But for whatever reason, the cases that we've had, it's probably because the sigmoid is more prone to perforation. The actual perforated colons from that pressure has been seen mostly in the sigmoid colon. Great, thanks.
Arthi, do you want to go?
Yeah, I can do a couple. So can you stop sharing your screen? Did you stop sharing?
I think I did.
Okay. I'm going to share my screen. Okay. So I need a volunteer, a senior resident from Loma Linda, because I think my residents may have seen this case already.
Senior resident, Daniel Fetzer.
Ah.
Wait, do you want to come up? The mic is up here. Daniel Fetzer is one of our fourth-year residents, doing mammo body next year.
Okay. I'm scrolling through a high-resolution T2 sequence of the pelvis. Unfortunately, I have very little control over my mouse, but...
It's perirectal fluid.
Okay, yep, there's a little bit of perirectal fluid. This is a female, and she presented with question of a imperforate hymen. Sorry.
Oh, that's okay.
Okay. Okay, I'm scrolling through. So what is this structure anteriorly?
Urethra there?
Yeah, so that's the female urethra, and that's kind of the normal zonal targetoid anatomy. And then back here is the rectum.
Mm-hmm.
And there's something that this patient does not have.
There's no uterus?
Yeah, and there's no uterus, and there's not even a vagina. So normally the H-shaped vagina should be right here. So that is missing. And then as we go higher, we can see though that she does have an ovary, and on the other images, we could see that she had an ovary on the other side as well. So do you know what that's called? So here's one ovary.
Is there like any renal agenesis or?
No, but that's a great question. So this anomaly can be associated with renal agenesis.
I'm assuming there's like a specific diagnosis that's.
There is an eponym, there's a name, but even if you just give the general, so basically you said that we did not see a uterus, and I also said we didn't see a vagina, right?
Correct.
So this is in the spectrum of Mullerian agenesis.
Okay.
It's also called Mayer-Rokitansky-Kuster-Hauser syndrome, but you can just call it Mullerian agenesis.
Okay.
And one interesting thing, so here's the urethra, here's the rectum, and we should see a vagina, a muscular vagina in between, but here there was actually there was soft tissue here and it was enhancing, but it was not in the shape or the normal morphology of a vagina. So this is basically a hypoplastic vagina. So a couple of teaching points.
Thank you.
So this was Mullerian agenesis. So here's another example of one. So you see your urethra, rectum, and no vagina here. It's agenesis of the vagina, uterus, or both. And in type A, you have normal ovaries and basically an absent uterus and upper 2/3 of the vagina. And type B is more severe, where you also have abnormalities of the ovaries and kidneys. So you always want to go check and make sure the kidneys are there. And the treatment is basically vaginal dilation, because this hypoplastic vagina can be dilated, and actually they can create a neovagina. So they might not need surgery to create a vagina. And then also counseling about fertility. So they won't be able to, have like intrauterine pregnancy, but they could have a surrogate. And they've also, some places have started doing uterine transplants. So that's something that might become more of a treatment in the future. Oh, so that's the end of that case.